A warm welcome to all of you joining us for eighth episode of Nephro Live, our ongoing journey into the world of nephrology education. It has been truly enriching experience over the past 7 episodes, and I am delighted to see the series growing stronger with your active participation. And guiding us throughout this journey has been none other than Dr. Dinesh Khullar, whose insight and expertise have been cornerstone of Nephro Live program. It is my privilege to once again welcome him as our guide for today's session. Dr. Khullar is currently chairman and head department of nephrology and renal transplant medicine Max Specialty Hospital, Saket, New Delhi.
Michael, sorry to interrupt. We can skip this part. People will get bored going through this slide time and again and again.
Sure,
Let's
sure.
let's come to the next one, which is more important. I'm really itching to introduce the worthy speaker and the elite panelists today. So if I may interrupt you to skip on to the next slide, please.
Sure,
Yeah.
sure, sure. So, so our focus today is on a critical yet often underestimated aspect of kidney disease, that is the anemia in chronic disease. So with this word, I hand over the digital podium to Dr. Ines Kula. Over to you, sir, and introduce our faculty for today's program.
Thank you very much, Mithlesh, and it's a pleasure to welcome you all to this next edition of Nephro Live. We are so excited to be here again with, I believe, a whole lot of people who join us, and I'm told eagerly look forward to hearing the top experts of in the field of nephrology from across the country, guiding them about the best ways of managing their patients with chronic kidney disease. Because we strongly, as nephrologists, believe that chronic kidney disease simply is not going to be manageable only in the hands of very few nephrologists across the country. It has to be a collective effort. Because look at the enormity of the situation, the gravity of the problem, and the huge number. If we believe, even if we believe that not 16%, but then maybe at least 10% of Indian population are suffering from chronic kidney disease, look at what it translates into when we look at our population of about 140 crores. So means at least about 14-15 crore of Indian population is suffering from chronic kidney disease. And we certainly need to brush our knowledge and spread the message to each other as to the kind of responsibility which we have on our shoulders to remain abreast with whatever is happening in the contemporary world of nephrology. Now, with that in mind, it's my pleasant task to thank INTAST, ably headed by Mr. Amit Arora, and very ably assisted by his team, wonderful team, starting with Dr. Mithlesh and Gaurav Khanna, who have done a splendid job over the last couple of years. Um, um, Managing the show here and helping us organize these on a regular basis, which certainly has become a very important landmark. At least that is what I personally believe, to spread the message and awareness about chronic kidney disease. And the beauty, as I always say, and I'm taking this opportunity to say that one more time, is is that they certainly agreed to our request that it will be a purely academic program. Only the science will prevail here, no branding. So thank you very much once again, Mr. Amit and your team, for talking only or helping spread only the message and without any branding. So that certainly speaks volumes about your true intentions. Thank you very much for that. So over the time, we have actually tried to segregate the chronic kidney disease into various kind of module um, subsets, whereby we started with talking about the causes of CKD, the definition, how do you label a given patient as having chronic kidney disease. We then progressed, moved on to talk about the common etiologies, and that is diabetes, and individually talked about what the magnitude of the problem is as far as diabetes is concerned, hypertension is concerned, and we talked about individually the management of that, as well as the management of mineral bone disease, which is a very common thing. So today we have something very important, And for that, today is no exception that I have carefully chosen the country's best in the field as far as the nephrologists are concerned, and certainly their interest in today's topic, that is anemia management of chronic kidney disease, is concerned. So it is my pleasant duty to introduce a brilliant nephrologist, Dr. Puneet Arora, who is a part of Max Healthcare as organization. He is the head of Department of Nephrology at Max Hospital, Dehradun. And after his DM in nephrology from the prestigious IPGMER Kolkata, he has gained a vast experience and is certainly one of the best known nephrologists, at least in this part of the country. He has been trained in various advanced procedures and has many research publications to his credit, both in the national as well as international forums. And of course, he's published a lot of articles. I'm sure he's going to do justice to what we have requested him to speak over the next about 15 minutes, just to give us an overview before we involve the elite panelists of today. And as I said at the outset, you certainly will never ever get disappointed, because we have the country's cream when it comes to the field of nephrology, and I can assure you today is no exception, because it's a matter of pride for me to introduce none other than Dr. Georgie Abraham, who is easily regarded as one of the most accomplished nephrologists of the country. And you see, my personal interaction with him dates back to the years when I was wanting to learn peritoneal dialysis, and the only name, or rather one of the very few names across the country, were that of Dr. Georgie Abraham as well. Peritoneal dialysis in India has all these years been synonymous with Dr. Georgie Abraham. So he's at the moment professor and head department of nephrology at Madras Medical Mission Hospital, Chennai. He has many important awards to his credit. He's been the president-elect Indian Society of Nephrology, which he's very soon going to take over this year. And he's been the president of Indian Society of Transplantation. He has been the founder trustee of a very important organization which have been helping people and researchers, and that is Tanker Foundation. And with his closeness to the family, he has done a human service to the research, and especially targeting the young people, the young nephrologists, the budding ones in the country. He's been the founder president, that comes as a no surprise, of Peritoneal Dialysis Society of India, and then whole lot of other accomplishments, a whole lot of publications, very very important ones across the various forums, both national and internationally, and he's been very deservingly awarded a whole lot of awards during his journey of so many years. So we have always been looking up to Dr. Georgie Abraham for the kind of advice which he has been giving to the youngsters, and certainly taking the Indian nephrology to the dizzier heights and making it known internationally. Thank you very much, Dr. Georgie, for all your contribution to the Indian nephrology, as well as in general, and peritoneal dialysis in particular, I would say. Up next, we're going to have Dr. O.P. Kalra, and I have been an ardent admirer of Professor O.P. Kalra right from my residency days, where I was his junior, who learned a lot of things from him, more than just the academic things, which he always was more than willing to impart to his juniors, but also the kind of passion he had as far as the field of nephrology is concerned, his enthusiasm, his real perfect discipline in life. There's so many things to learn from him. And after that, he worked at the prestigious University College of Medical Sciences here, where he was the principal, and then he superannuated as the vice chancellor of the prestigious Pandit B.D. Sharma University of Health Sciences, Rohtak, Haryana. During this journey, he has many awards to his credit, but then the icing on the cake was the Dr. B.C. Roy National Award in the eminent medical teacher category, which was conferred to him by the Honorable President of India, quite deservingly, I would say. Whole lot of very nicely written scientific papers, and he has, as you know, been a teacher of many teachers. So certainly, it's, as I said, always a treat to listen to him, to learn from him in the in the various aspects of nephrology. So we are, thank you very much, Dr. Kalra, for agreeing to be
Thank
a
you,
part
Dr.
of this
Fuller.
meeting. Dr. Avinash, another very dear friend of mine from Pune, another fantastic and a very knowledgeable nephrologist. He's HOD and a senior consultant of nephrology at Nobel Hospital, Pune. Has whole lot of interest in nephrology after he did passed from All India Institute, Delhi, way back in 2004, after which he has very ably been taking nephrology to further heights, especially has contributed immensely to Pune, because he was the founder member of the Pune branch of Indian Society of Nephrology, which has come up very, very nicely. Already a force to reckon in the field of nephrology in India, at least. And what brings him very close to me on a personal note is our association through many and important clinical trials. We have both been part of DAPA CKD, Olympus, Rockies, Find CKD, etc., which has certainly given me a chance to interact with him and learn how amazing a person and knowledgeable he is. Thank you very much, Avinash, for joining us today. And again,
Thank you so much, sir.
last but not the least, it's a pleasure. In fact, I'm very happy to introduce Dr. Ritesh Kontia, whom I've had the pleasure of knowing for last so many years. First, as a student during his days at Sir Gangaram Hospital, where he came out as a brilliant resident, and then subsequently my own colleague at Max Hospital Saket, where again he left no stone unturned to ensure that the department progresses further and really very well. So it was with great difficulty we allowed Ritesh to move on and migrate to Calcutta for his personal reasons, and I know that in Calcutta he has really made a mark for himself. He's done brilliant job, and which was quite expected from him, the kind of sheer passion and knowledge which he always possessed, and obviously within a short span of a few years he has come out with some lovely presentations and this thing. So I think,
Thank
well,
you,
let's
sir.
move on and try to just tell everyone. And we generally believe close to about 2,000 people from across the country join us on a monthly basis to learn from what these stalwarts in the field of nephrology have to share with them. So today, as I said earlier as well, we are going to talk about anemia management in renal disease. And just to give a brief overview, you see, I certainly, if I look back in over the last my about close to 4 decades of journey in the field of nephrology, two or three things have been striking, and I think I would be not exaggerating if I share that anemia management is certainly at the top of our accomplishments over the years, because no matter what you did via the effective management of chronic kidney disease, or even putting them on dialysis as in when the situation arose, the quality of life was not improving at all till the time we came out with something which was actually able to manage their anemia much more effectively. So gone were the days when we only had to rely on blood transfusions, because we all know anemia is an integral part of chronic kidney disease. And as the disease progresses, and by the time they are in the advanced stages of CKD, almost all, at least 90% of them, have a fairly significant anemia. So even if you were able to take care of all other things and yet not able to do anything for anemia, I think the quality of life was never ever going to be good. So we were relying on the dangerous sorts of iron preparations, the iron dextran and whole lot of things. So we were wary of them on one hand, and then it takes me to those days where I was a resident, and we used to come across people who would be traveling from countries like USA or UK, and they were holding some vials with them, and as if that was, they were like magic potions. So when we tried to figure out what that was, so they would hold it very, very carefully, as if it was some diamonds or some great treasure in their hands, because they were told that this is the greatest thing to have happened in the management of CKD, and that was erythropoietin. And it certainly changed the way we were looking at anemia management. And I am also reminded of the fact when I, as a senior resident, was assisting my Guruji, the late legendary Professor K.S. Chugh, who was organizing the Asia Pacific Congress of Nephrology somewhere in December 1992. December 92. I hope why I'm specifying this, because there were a lot of cancellations, unfortunately, for those things which happened, but fortunately for the conferences went on uninterrupted. And during that conference in 1992, the India's first erythropoietin was launched by the name Hemax, and I still vividly remember the balloon which went up in the air at the time when we announced the launch of India's first indigenous erythropoietin. So game changer. So certainly a very welcome thing, but certainly we realized that it also had its serious consequences. So if we were not well conversed with the use of erythropoietin, we were likely to burn our fingers. So we learned over the years that misuse of erythropoietin was certainly not the way forward. And I'm sure Puneet is going to tell us why this caution and what did we learn over the years. And then, of course, over the years, we also learned the importance of iron. We certainly realized that it was not the absolute iron deficiency, which is very common. All those causes of anemia which are applicable to the general population are also applicable to the patients with chronic kidney disease. But when we talk about anemia and chronic kidney disease, the two major things which come to mind are the lack of erythropoietin, or maybe some toxins not allowing erythropoietin to act. And the other hand, we have iron deficiency. It is not the absolute iron deficiency all the time, but it's the functional iron deficiency, which again, I'm sure Puneet, or maybe in the discussion to follow, we will talk about what really this concept of functional iron deficiency is. And then we realized there was a villain sitting in the body called hepcidin, which was made by the body for some right reasons. But then when it came to chronic kidney disease, hepcidin was acting as a villain. So we needed to find ways to overcome this hepcidin, so that the resistance to erythropoietin, because we were finding that there were cases where erythropoietin was not acting in spite of using very high doses. And on the other hand, if we use terribly high doses, or we attempted to increase the hemoglobin beyond a certain value, it was going to backfire. And then we realized as to why. So we now started focusing on eliminating those areas, issues which were not allowing erythropoietin to act. Certainly, as I said, life needs to move on, and comes in a time when we believe that yes, erythropoietin may have been a great thing for the cause of management of renal anemia, for all these suffering people, but we needed something even more, or maybe better, or at least a decent alternative. So with that in mind, we recently had a new concept of something called HIF-PHIs, which is hypoxia inducible factor pruryl hydroxylase inhibitors. So that's a fantastic kind of concept, which tells us as to why in the plains we do not have a very high hemoglobin value, but the moment we go onto the mountains, our hemoglobin rises because something happens. So some three people who were subsequently awarded Nobel Prize also for this discovery, realized that if we act at the similar level, maybe we are able to come out with something which can help overcome this phenomena. And in the form of an oral tablet, we can do what erythropoietin was doing, or at times erythropoietin was not able to do. But as I said, the caution with everything, these HIF PHIs came with their own cautions, whereby people realized that yes, it will be very important to have a great class of drugs called HIV-PHIs. But then you see, it was not just the erythropoietin they were stimulating. There were many unwanted genes which they could actually inadvertently stimulate, which could result in something like malignancies or vascular issues, or increase in the size of the cysts, etc., which again I'm sure Puneet is going to discuss today. So whole lot of things which have really revolutionized the way we have looked at the anemia management over the last so many years. So I will now request Dr. Puneet Arora to briefly give us an overview of what the concept of renal anemia management is all about. And this will be followed by, which I'm sure, a wonderful discussion, which everyone is going to thoroughly enjoy with what these stalwarts are going to throw at us. Thank you very much. Over to you, Puneet.
Thank you, sir. Thank you, sir. Sir, are the slides visible?
Yes, yes. And you can move them now.
Good evening, sir.
Yes.
First and foremost, I thank Dr. Kullar, sir, for making me part of this program. And today, I would be discussing primarily the salient features of KDCO 2025 clinical practice guidelines for anemia in CKD in next 15 minutes allotted to me. First, the key takeaway message. This 100 pages guidelines tend to convey is that as anemia correction with erythropoiesis stimulating agents and HIF-PHIs is associated with various adverse outcomes, so practice pattern as of now should shift towards reduction in ESA and HIF-PHI use and increase in iron supplementation. Why I'm saying this, we'll see in the subsequent slides. The definition of anemia in CKD is same as in general population, that is in the age above 15 years, less than 13 in males and less than 12 in females. But maintaining a hemoglobin higher than 11.5 does not improve survival in people with anemia and CKD and may result in adverse cardiovascular outcomes such as stroke. The potential for further improvement in quality of life when hemoglobin level are maintained above 11.5 is uncertain and in some trials was not considered clinically significant. So the target hemoglobin in adults with CKD is less than 11.5. In children, observational data suggests that hemoglobin concentration more than 12 are not associated with increased all-cause mortality or cardiovascular related hospitalization in children on hemodialysis. The factors unique to children, that means the data from adults may not apply, are development and psychological factors, lower risk of cardiovascular events, and potentially greater importance of avoiding allosensitization to facilitate kidney transplantation. The outcomes associated with anemia in CKD are higher mortality, higher risk of coronary heart disease and major adverse cardiovascular events, more left ventricular hypertrophy, increased risk of heart failure, lower quality of life, higher transfusion requirement, lower work productivity, more cognitive impairment, increased risk of dementia, and more hospitalization. But normalization of hemoglobin levels failed to improve most adverse outcomes except improvement in quality of life and lowered the transfusion requirements. So accordingly, it remains uncertain whether anemia plays a causal role in adverse outcomes associated with anemia beyond improvement in quality of life and transfusion requirement. Whether anemia causes increased risk of kidney failure or accelerate the progression of CKD is also uncertain, though there have been studies where the adverse kidney outcome have been seen with the anemia, the presence of anemia. Potential causes of anemia, which may be multiple in CKD, are the first and foremost the iron deficiency, erythropoietin deficiency or hyporesponsiveness, blood loss primarily through gastrointestinal tract, angiodysplasias, malignancies, and during dialysis, shortened RBC survival, hyperparathyroidism, or thyroid dysfunction, which is very commonly ignored. bone marrow suppression by inflammation, drugs, or malignancies, and other nutritional deficiencies like B12 and folate, chronic inflammation like obesity, CHF, and inherited anemias like thalassemia. Now, there are two types of iron deficiencies in CKD. The first, the systemic iron deficiency, in which the stored iron reflected by the ferritin is less, and the available iron, the functional iron reflected by the transferrin saturation is also less. And the more common, the iron restricted erythropoiesis, in which either there is the adequate or more ferritin levels and the transferrin saturation is less. To understand this, let's a few things about the pathophysiology. The iron in body bound to transferrin is the major two sources are the intestine, primarily absorbed from duodenum, and the other is the recycling of the iron from the senescent RBCs by the macrophages, which is the major source. More than 85% of iron is provided by this. So this iron bound to transferrin is either stored in the form of ferritin in liver or spleen, or available to bone marrow for the erythropoiesis. Now, there is a hormone, hepcidin, which is secreted by liver, and when it gets attached to the ferroportin, the only known iron transporter known to medical science right now, it causes degradation of ferroportin. So when it causes degradation, the absorption of iron is less, and this ferroportin is also present on the macrophages, and the iron gets sequestered. So in normal conditions, this recycling of iron from the senescent RBCs is efficiently done by the macrophages through ferroportin, and then to transferrin added to the transferrin saturation and move to the bone marrow. But in systemic iron deficiency, this available iron is less. But in spite the lower availability, the whole sequestered iron is made available by the presence of low hepcidin through ferroportin to the transferrin and subsequently to the bone marrow. But in presence of in chronic kidney disease, this hepcidin is high because of lower excretion from the kidneys, as well as the more production because of inflammation. So this iron, recycled iron from the senescent RBCs, gets sequestered in the macrophages itself and is not made available to the transferrin saturation. So this is called the functional iron deficiency, or more sensible, the iron restricted erythropoiesis, which is the major reason of iron deficiency in chronic kidney disease. So the potential causes of iron deficiency in CKD is the chronic inflammation, which is because of the increased hepcidin, bleeding, which can be from the GI or urogenital tract, iatrogenic like drugs, AC inhibitors, ARBs, multiple phlebotomies, or in hemodialysis, poor intake as the appetite is less, and increased iron consumption due to use of ESAs, or increased EPOs production by graft in the kidney transplant recipients. So what are their recommendations? In patients with CKD5 on hemodialysis, initiate iron therapy if the ferritin is less than 500 or TSAT is less than 30%. IV iron to be preferred over oral iron, and administer IV iron using a proactive approach to maintain stable iron status. So where they get this term is from the pivotal study, where they supplemented iron in two ways. One in the reactive fashion, where up to 400 milligram IV iron sucrose was provided if the ferritin was less than 200 or TSAT was less than 20%. And the another group was provided, was dealt in a proactive fashion, where monthly IV iron, 100 milligram weekly basis, 400 milligram iron was given, and was only withheld if the ferritin was more than 700 or the TSAT was 40%. And they found that the requirement of ESA and the better anemia management with the proactive approach to the iron supplementation. So those patients who are not CKD patients who are not on dialysis or on peritoneal dialysis, iron supplementation to be done when ferritin is less than 100 or TSAT less than 40, ferritin between 100 to 300 or TSAT less than 25%, either oral or IV iron based on the person's value or preference can be given, either oral or IV, and switch from oral to IV iron if there is an insufficient effect of an optimal oral regimen after 1 to 3 months. Withhold iron if the ferritin is more than 700 or the TSAT is more than 40%. The more intensive IV iron administration may be associated with increased risk of mortality and infections. There is a theoretical concern that iron could be deposited in tissues or that non-transferrin bound iron could have direct toxic effects, although this has not been well studied in people with CKD. In people with CKD treated with iron, consider temporarily suspending iron therapy during systemic infections. A theoretical and experimental evidence to suggest that iron administration may worsen an existing infection, but clinical evidence is lacking. Moreover, the briefly suspending iron therapy until the infection is cleared is unlikely to significantly affect the progress of iron replenishment to correct anemia. Pre-treatment with corticosteroids or antihistamines is not routinely necessary with IV iron, and test dose of IV iron are not usually required because lack of response does not predict the risk of hypersensitivity. So this should be given in a setup where such kind of reactions can be easily dealt with. Now, consider treatment with oral or IV iron, especially in symptomatic patients with advanced CKD when there is a profound iron deficiency but no anemia, reflected by if the ferritin is less than 30 or the TSAT is less than 20, or in an indirect way the MCV is less than 80, then iron to be supplemented even if there is no anemia. The rationale behind is the iron fulfills many more functions beside being the fuel for erythropoiesis, including DNA synthesis, iron, electron transport, and cellular proliferation and differentiation. Anemia is the end phase of depleted iron store, and hence correcting iron deficiency prior to the occurrence of anemia makes sense. And observational data in people with CKD and kidney transplant recipients underscores this, as iron deficiency, independent of anemia, is associated with higher risk of all-cause mortality, MACE, and worse patient-reported outcomes. So this is the table which compares oral iron and with IV iron. With oral iron, there is a slower increase of hemoglobin, ferritin, and TSAT, but the side effects, primarily GI side effects, are more frequent but less severe. With IV iron, the response is faster, the side effects are less frequent, but when occurs, the side effects are more severe. Now coming to the ESA versus HIF-PHI, in people with anemia and CKD, in whom correctable cause of anemia have been addressed, ESA rather than HIF-PHI as first line of therapy for anemia. It should be a shared decision with patients considering individual symptoms, potential for harms from RBC transfusions, and potential risk of adverse events with ESAs as well as HIF-PHIs like stroke, cardiovascular events, and cancer. Now, this recommendation of preferring ESA over HIF-PHI places a higher value on the well-documented benefits and risk of ESA treatment and a lower value on the putative advantage of HIF-PHI, such as oral route of administration. Though the convenience of this may lead to more compliance, although head-to-head RCTs revealed non-inferiority of HIF-PHIs versus ESAs for efficacy, some studies suggested a higher risk of MACE and vascular access thrombosis and with HIF-PHIs compared to ESAs. And also the long-term risk and benefits of HIF-PHI in the broader population of patients outside clinical trials are still unknown. So there are theoretical risk or experimental evidence of risk or disease development or progression with HIF-PHI in cases of active cancer or with a history of cancer not in complete remission for at least 2 to 5 years, polycystic kidney disease, proliferative retinal disease, pulmonary hypertension, and pregnancies. Concerns for risk based on adverse event profile in clinical trials include the strokes, history of stroke, MI, history of DVTs, pulmonary embolism, prior vascular thrombosis, hepatic impairment, and seizures. And there is insufficient data, so not to be used in children and post-kidney transplant anemias. ESA initiation in patients who are on dialysis, whether hemodialysis or peritoneal dialysis, when hemoglobin is less than 9 or 10, then to be considered for when the all other things have been addressed, the ESA initiation. But the patients of CKD who are not receiving dialysis, including kidney transplant recipients and children, there is no cutoff. Consider the presence of symptoms attributable to anemia. Consider the potential benefits of higher hemoglobin concentration, and consider the potential harms of RBC transfusions or receiving ESAs. Suspend ESAs during hospitalization for acute stroke, vascular access thrombosis, or thromboembolic events. Reinitiation of ESA therapy should be based on shared decision after discussion of benefits and risk, as 1 in 4 stroke survivors will have another stroke. ESA hyporesponsiveness. Inflammation and iron deficiency are the most common causes, and in 30% the cause is unexplained. There is increased risk of cardiovascular events, kidney failure, and death, and the HIF-PHIs can be tried after discussing pros and cons, but do not use ESAs and HIF-PHIs in combination. People have been using it, but in the published literature, there's only one study I could find of 5 patients in Poland where they found the beneficial effect. Benefits of RBC transfusion may outweigh its harm when ESA or HIF-PHI therapy is ineffective, like hemoglobinopathies, or ESA or HIF-PHI therapy is harmful, like previous or current malignancies. In people eligible for organ transplantation, avoid when possible RBC transfusions to minimize the risk of allosensitization. Like we commonly tell patients that leukodepleted RBCs are comparatively safer, but it's not the real scenario. Leukodepletion of blood products does not decrease the risk of allosensitization in previously transplanted or in potentially future kidney transplant candidates, as the number of HLA molecules contributed by RBC is comparable to that of leukocytes. There is no hemoglobin cutoff. Decision to transfuse a person with CKD and chronic anemia should be based on symptoms and signs attributable to anemia rather than arbitrary hemoglobin threshold, and avoid RBC transfusion in patients with chronic anemia who are asymptomatic. Now, I end with a case that is a 56-year-old woman with a CKD stage 5 due to polycystic kidney disease, anemia attributed to CKD, hypothyroidism, breast cancer, and a lower extremity DVT 3 months ago, present for the regular follow-up. The patient's breast cancer was discovered on a screening mammogram when she was undergoing workup for her kidney transplantation, and she was treated with lumpectomy, radiation, tamoxifen, which is planned to continue for additional 2 years. She denies shortness of breath, palpitation, postural dizziness, or uremic symptoms, although she has limited some of her activities because of fatigue. And the medication, she is on oral iron, soda bicarb, levothyroxine, and apixaban. The creatinine is 3.2 with a GFR of 14. Hemoglobin is 7.8, and 3 months ago it was 8.2. Iron saturation is 31%, ferritin is 492, and B12, folate, and TSH are within the normal limit. The most appropriate next step in management: observation, erythropoietin, blood transfusion, iron sucrose, or desidustat, the only HIF-PHI available in India. So the American Society of Clinical Oncology and American Society of Hematology guidelines says that ESA may be considered in patients with chemotherapy-associated anemia whose cancer treatment is not curative in intent and whose hemoglobin is less than 10 grams. Oncology guidelines do not address ESA use in patients with cancer and CKD. Their guidelines only target patients with chemotherapy-associated anemia. ESA use is associated with increased risk of cancer and poorer outcomes, including increased mortality. These observations came from trials in the early 2000s when the normal hemoglobin up to 13 to 16 gram was targeted. And the KDIGO guidelines recommend using ESAs with great caution, if at all, if cure is the anticipated outcome. So in this case, my take would be just observation, as erythropoietin, when the cure is the intent in this patient, should not be the preferable modality. Blood transfusion in a stable asymptomatic patient should not be a reason to transfuse, though it should be a second step. Iron sucrose, when the iron is depleted, no point, and desidustat should not be a good answer. Thank you.
Well, thank you very much, Puneet. That was excellent and very, very concise and excellent overview of where we stand in terms of our understanding of anemia management. And just to share with everyone. KDIGO guidelines are sacrosanct to most of us in the field of nephrology, and we do give a lot of importance to what is written or conveyed via the KDIGO guidelines. The draft is out, and we are going to very soon have these incorporated into the guidelines, and something which everyone expects us to follow most of the times, if not 100% of the times. But because we always believe that it is the patient sitting in front of us who is the most important, rather than blindly following any of these guidelines. So common sense after adequate scientific knowledge should always prevail. That's what most of us would truly believe. So at this stage, if you can stop sharing your slides, Puneet, so
Yes,
that
sir.
we can
I'm doing it.
invite the all the panelists, and I'm quite excited to start this discussion. So my first question is to you, Puneet, just for a few clarifications. You see, because I had said at the outset that we need to brush our knowledge as far as the key concept of the type of iron deficiency is concerned. So can you, for the sake of not at the risk of repetitiveness, but then at least for the sake of everyone to understand one more time as to what is functional iron deficiency all about? I mean, we do know that the absolute iron deficiency is where the serum iron is low, the TIBC is high, and the ferritin is low. We know that, and especially seen in females across the world, and we know that's the iron deficiency we always have been talking about. But when it comes to the field of nephrology and anemia in the context of CKD, there's this concept which you have alluded to called functional iron deficiency. May I request you to one more time elaborate the concept?
Sir, the concept is that the major iron available in our body is through the senescent RBC recycling by the macrophages. They take out the iron from the senescent RBCs and through ferroportin provided to the transferrin. So this iron is either stored in liver or provided to the bone marrow for the production, recycling, again production of the new RBCs. Now in presence of hepcidin, hepcidin is normally secreted by the liver, but in presence of CKD, the value, the levels of hepcidin are higher because of the reduced excretion and the more production of inflammation. This hepcidin causes degradation of ferroportin. Ferroportin is the only iron portal which transmits iron from enterocytes as well as from the macrophages. So when this gets down regulated, so this available iron is available, but that gets sequestered either in the enterocyte or in the macrophages. So the ferritin level is okay. The available the iron stores are okay, but the available iron provided to the bone marrow is insufficient because of the hepcidin levels, the chronic inflammation.
Yeah, so I think a very important concept, because we in our patients will tend to see that the ferritin levels are either normal or high, or at times abnormally high, because we all know that ferritin is a acute phase reactant in so many infections, chronic inflammatory states. Ferritin goes up, and if we were to try to monitor ferritin, we will probably fail to understand that actually speaking, the stores may be there, the ferritin may be there, but the body is not able to utilize it. So that is when you come across a situation where iron may be low or normal, but TIBC is low and ferritin is high, and you would believe that you will have to struggle to overcome anemia in these kind of patients. So let me at this stage involve the elite panelists. So my first question is to you, Professor Kalra, that you see, we have always believed, and as I said earlier, it's when you talk about anemia in renal disease, the two things which obviously come to mind are, one, we have just now discussed, that's the role of functional iron deficiency, and the obvious things, even many lay people would know that the seat of production of erythropoietin is a kidney. So obviously when kidneys take a hit, erythropoietin is not there, and that is what is causing anemia. So would you want to elaborate, Professor Kalra? Is this the only cause of anemia, or when it comes to your mind, there are so many others which you would always want to keep in mind to pinpoint the cause of anemia in a given patient of chronic kidney disease?
Thank you, Dr. Dinesh, first of all, for inviting me. As Dr. Puneet has very ably described, the anemia in cases of chronic kidney disease is not only due to the fact that there is universal deficiency or there is a problem with iron availability, but it's multifactorial. And we have to make sure that there are other factors which are correctable. Those are also taken care of. For example, certain drugs like ACE inhibitor, ARBs, they may also add to anemia. So if a patient is having anemia which is not responding, then we have to look at this. We have to also look at thyroid problem, hypothyroidism, hyperparathyroidism may also add to this thing. And of course, the uremic milieu itself, because the uremic toxins are having an effect on the RBC survival, and also they induce a state of chronic inflammation. So all these things, they add towards anemia. But of course, the most important cause among all these is the iron deficiency, and it is the functional iron deficiency, where we need serum iron and total iron binding capacity, and we can calculate it easily. Serum iron over TIBC multiplied by 100, we find that transferrin saturation. So therefore, we have to make sure that if a person is having transferrin functional iron deficiency, as evident by low TSAT levels, the other serum ferritin level may be high, because earlier on the term which was used, functional iron deficiency, now the nomenclature has been changed and it is now called iron restricted erythropoiesis. And the absolute iron deficiency which we were using, where the transferrin saturation is also low and the serum ferritin is also low, there we are now using the terminology as per the KDIGO, systemic iron deficiency. So it is the iron deficiency or the functional iron deficiency which is the most important thing. And the KDIGO draft guidelines which are available for public review since November last year, and the final guideline may come anytime. So they also emphasize to a great extent the role of iron therapy, and the pivotal trial 4 5 years ago has also emphasized that it is the proactive treatment rather than reactive based on the serum ferritin level. So therefore, the emphasis is more and more on iron adequacy in the stores. So, but we have to at the same time make sure that we don't overload the person. So therefore, monitoring has to be done, and it is recommended that patients of stage 5, uh, I mean, whether on dialysis or not on dialysis, we have to monitor the iron parameter every 3 months. While those who are in the earlier stages, say stage 3, we may monitor just once a year or so, or stage 4, once in 6 months. But in stage 5, we must monitor this every 3 months. So therefore, it is very important that we must make sure that iron deficiency is the one which is taken care of in these cases. So that is what is the most important factor. Yeah.
Thank you very much, Dr. Kalra, for emphasizing a very important point. And this has been our learning ever since we came across erythropoietin. We probably initially thought that our search is over. We should focus only on erythropoietin and forget about everything else. It is only time which has taught us that that is indeed not the case. Erythropoietin, which came in as something very expensive, certainly is fraught with risks, and certainly, as I said earlier, and what Puneet amplified quite nicely alluded to, that we need to understand the art behind the use of erythropoietin and its usage. But what
Yes,
we were ignoring was the key role of iron all these years, and maybe to some extent because of the fact that the previous iron, at least the intravenous iron preparations, were not safe. I am talking about the old iron dextran, etc. It is only with the availability of iron sucrose that we felt very comfortable giving intravenous infusions of iron to our patients. And more recently, carboxymaltose and isomaltoside have really made our task rather easy when it comes to intravenous iron. But what is very important for everyone who have logged in today is to understand that it is not absolute iron deficiency whereby just oral supplementation may suffice. But when it comes to managing our patients of chronic kidney disease, many a times, rather most of the times, you have to resort to intravenous iron. So it's a blessing to have these safer alternatives. And gone are the days where we would look at just a figure of 100 nanograms of ferritin as our ultimate goal. We are transcending the boundaries, as Puneet has very nicely alluded to with that landmark pivotal trial. We don't stop anywhere, even up to 500. 700 is the target. Few people don't know where to stop. They go up to even up to 1,000. But I think then the more complacent you become, the more adventurous you become, you are going to burn your fingers there as well. But then the safe is what Puneet has told us today. So I think it's life is not just about erythropoietin. That's a key message which we as nephrologists are telling. The whole focus has shifted on to relatively cheaper alternative, which is you have no business to move on to erythropoietin till the time you have made sure that your patient is iron replete. So that's the key. And thank you very much, Dr. Kalra, for letting us know the newer terminologies, so that in times to come, we are certainly going to refer to those new terms. So Dr. Georgie Abraham, please. So with your vast experience, and no one better than you to have really seen that paradigm shift in the way we have looked at anemia, sir. What is your take on the role of chronic inflammation? Because our patients, of course, on one hand, have all the reasons to become anemic because of the various factors which are applicable to a normal person who does not have CKD. But when it comes to CKD, the things which come to mind, first of all, are the chronic inflammatory state, the oxidative stress for so many reasons, and of course, what we heard today, the terrible villain called hepcidin. So, what is your take on the role of chronic inflammation, hepcidin, and do you think our terminology, the way we talk about renal anemia, should integrate the etiology behind it rather than base it on just hemoglobin values? And one more time, may I request you to let the viewers know today as to what is the kind of target hemoglobin you have in mind while uh, tackling anemia of renal region. Dr. Georgie, sir, you're on mute, sir. Kindly unmute yourself, sir.
Can you hear
Yeah,
me?
it's
Yes
fine.
or no?
Absolutely fine. Absolutely fine.
Okay.
Yeah.
Thank you, Puneet, for that overview, which was excellent. And Dinesh, thank you for bringing this question of anemia. Because arguably, anemia is the most important correctable factor, and also the adverse effects due to anemia, we all know. Now, many of our patients, whether they belong to male gender or female gender, or they are not on dialysis, they have inflammatory state. This inflammatory state will lead to anemia to a large extent because the blast forming unit and the colony forming units, which are in the bone marrow, they are not able to function to make RBCs. So the question is, what do we do? One of the simple ways to look at the inflammatory state is to look at the CRP level. If the CRP level is high, we know that these patients are inflamed, and despite giving erythropoietin or any other molecule for that, it may not correct it. But we all know that the HIF PH1 have anti-inflammatory activity, and also it releases iron because it inhibits hepcidin, which is produced by the liver. And we also do have liver inflammation in a lot of our patients who are chronic kidney disease and who are on dialysis. And this may also have an impact on the increased levels of hepcidin in the blood. So we all know that the side effects of ESA, and we feel that the erythropoietin usage can increase the erythropoietin to a great extent over supraphysiological levels and lead to complications. Whereas when we use the HIF PHI1, the erythropoietin level, although it goes up, it does not supersede the physiological level. And at the same time, it will also reduce the hepsin and make iron more. So the question is, what should be our target of hemoglobin? It should be 11.5. It should not exceed, except as the Puneet said that in pediatric group, we can go up slightly more. So should we use and HIF PHI? I was attending the American Society of Nephrology meeting last year in San Diego, and it's a symposium. And the symposium did not give us any definite guidelines as to use HIF PH1. And although we know that it has benefits and it can increase the hemoglobin, it doesn't need to be given by parenteral route. It can be taken orally, but the long-term effects such as thrombosis, embolism, and then hypothyroidism is one of the other effects. And what are the other long-term effects? We are not sure about that. So inflammation should be tackled. One way of tackling the inflammation to correct the anemia is to use pentoxifylline. Pentoxifylline has been used in a number of studies, which reduces the inflammation and increases the hemoglobin. So that would be my comment.
Well, thank you very much. That's been
Hello.
very useful, and I think that a lot of experience behind those comments, sir. I think we're going to come back to you to learn more about these. But then, for the time being, the next one is for you, Avinash. With your experience, you see, on a daily basis, you have to interpret reports, and patient of chronic kidney disease comes to you, and you have asked for a few investigations. How do you interpret those, and what in your mind is the most reliable marker for diagnosing iron deficiency? Because we have emphasized a lot on addressing the issue of iron deficiency, but to make a good diagnosis and correctly interpret the markers in front of you, and while you are there at the important ones which we have in our kitty currently, would you go one step further into the minutest details and get those investigations done, which all these years have been little on the experimental basis? A little cumbersome ones. Do we really need them for the interpretation, or the currently available, the standard iron, TIBC, and ferritin will suffice for you be able to make a diagnosis of the type of iron deficiency your patients have? Avinash.
Yeah, it's a very relevant and a very practical problem which we face every day. And the conventional learning which we have had from our teaching days is that we look at two things. That is the saturation, that's the serum iron and the binding capacity, and the serum ferritin level. We haven't had any new marker for a long time, and this is what we had to base our decisions on. So now the challenges come with that ferritin, though it's relatively cheap and available in most places, it's an acute reactant and it falsely gets elevated in inflammation. And our patients, they have chronic inflammation, infections, catheters, fistulas, and it can really affect the ferritin levels quite inadvertently. So we may have ferritin in patients who are from like 100 to even 800 without, and even when the iron function is low. And ferritin level being less than 100 or less than 200 in a dialysis patient would indicate deficiency. But if it is more than 500, more than 800, it doesn't tell us anything in that scenario. So it becomes alone a relatively a test which one can tell us if it is low, but it doesn't tell us much if it is high. Iron saturation, that is the serum iron and the TIBC ratio. If it is less than 20%, it indicates iron deficiency. But even this, although not as much affected by inflammation, does get affected to some extent. There are some diurnal variations, some food intake, and of inflammation. So alone TSAT also might not tell us. If we only look at that without looking at the ferritin, we might miss out iron deficiency, where TSAT may be little high, but still the ferritin may be low. So combination of this does help us in a certain way, but still that leaves much to be desired. One of the newer markers which have been discussed in the last couple of years or maybe a decade, but has not been available and not been a point of discussion except for recent, is what is called as the reticulocyte hemoglobin content. And it is a direct measure of the iron which is available for erythropoiesis in the previous 3 to 4 days. So it is not affected by inflammation like ferritin or the TSAT, and detects functional iron deficiency much better. The only problem is that it is still probably not available in most places. At least I checked with lab and iron, they still don't have it. I'm not sure about the other centers. Still, reticulocyte hemoglobin content is much better than other two, but the availability can be a challenge. And in certain scenarios, like in thalassemia, it may not give a correct picture. And also when we have macrocytes, it may again not give a very good picture. So some areas where we may still be, have to be careful interpreting its values.
So in majority of the cases, Avinash, I'm sure you would agree that iron, TIBC, ferritin gives us the sort of information which we are wanting. And I think Dr. Kalra alluded to that. It's just dividing iron and TIBC, and you get the transferrin saturation if you multiply it with 100. So I think it's the basics are always going to help us. With that knowledge, Ritesh, may I ask you, and there's a very interesting question here posed by Dr. Verma in the chat box. Do we need to screen and manage iron deficiency even when the actual anemia has not as yet developed? That's one component of the question. But what is equally important is what we nephrologists face very often, and that is, should iron therapy be continued even when hemoglobin normalizes? And but the TSAT and the ferritin levels have not the ideal values have not been achieved, which means is there a risk of overtreatment? So I think I'll break my question into two. One, what Dr. Verma wants to know, that even when everything is normal, patient has chronic kidney disease, yet the iron indices are normal, would you want to treat? That's one. So that before, as we had said earlier, before giving them erythropoietin, you basically would be wanting to ensure that the iron levels, the patient is iron repleted. And secondly, equally important, what is the end point? Would you want to stop even when the hemoglobin has now been achieved, the right value, yet the ideal value of ferritin has not been achieved? Ritesh, over to you. Ritesh, you're on mute, please. Kindly unmute yourself. Kindly unmute. Yeah.
Yeah. Thank you, sir. Thank you, sir, for having me here. So basically, like we have heard about the absolute iron deficiency and the functional iron deficiency. And as we all know that iron supplementation is one of the important things which is required in anemia of chronic kidney disease. So alluding to the first question that if the iron indices are normal, whether supplementation is required in those patients. So if the indices are normal, that is that the patient is not having absolute iron deficiency, then maybe it is not required. And if in those patients, if the patients are being treated with the ESAs and still the hemoglobin is on the lower side, and we are thinking of functional iron deficiency in those cases, that is the time we think of supplementation with iron. So if the patient has absolute iron deficiency, we need to treat with iron. And if the patient doesn't have, then we have to see what is the anemia level and whether the patient is on any therapy, ESA therapy or not. The second part of the question is that if the patient has the hemoglobin has normalized, but still the ferritin levels are low, that TSAT is low, whether we need to treat those patients or not. So basically, we need to replete the stores of the patient if the patient has iron deficiency, because iron deficiency per se can, these patients per se can have symptoms of fatigue, generalized weakness, which can persist even if the anemia has been corrected. So to replete the stores, we need to continue with the iron therapy, but we have to be careful that we need to monitor this iron status, that is TSAT and ferritin, in these patients in whom we are giving iron therapy. And when the levels start going up, that is the time we have to think that we have to stop iron supplementation in those cases.
Excellent. Thank you, Ritesh, for those comments. And I think we now move on to something very interesting. And Dr. Patil has addressed this issue, and I'm going to ask Dr. Kalra to answer that for us. Dr. Patil wants to know: does anemia correction improve the renal and cardiovascular outcomes, or is just about quality of life improvement, as in the case of heart failure? That's one. And the first, before you address that issue, Professor Kalra, my request is you to tell us whether you believe that early anemia correction can actually slow down the rate of CKD progression, or is it just, as he had asked, a quality of life issue? You raise the hemoglobin, patient starts feeling better, or is it doing something to CKD progression as well? And at the same time, since we believe that cardiovascular disease and chronic kidney disease progression go hand in hand, which means addressing anemia of renal origin is going to mitigate the occurrence or progression of the other as well. Dr. Kalra.
Dr. Khullar, actually, a low hemoglobin level, of course, is associated with poor quality of life. There is no doubt about that. But then it has also been associated with several other things, such as overall survival is lesser. Mortality, including the cardiovascular mortality, is also lower in these cases. In addition to that, there are more chances of these having left ventricular hypertrophy, cardiac failure, and overall, I mean, other factors like cognitive function impairment, and uh, there are so many other things which are associated with poor hemoglobin, poor muscle mass, and general debility. But then it has been seen that even when you correct anemia with iron and erythropoietin, all these things may not get reversed, because actually all these things are not attributed only to anemia. There are many other things also which are playing a role in this, whether it is uremia per se, or it is hypertension associated with these cases, or salt, fluid, potassium, other things may also be playing a role. So therefore, correcting anemia may not reverse all these things, but certainly quality of life improves in these cases. One thing which you asked, that whether uh, progression of kidney disease is also halted in these cases once you correct anemia. Uh, there have been few studies actually which have shown that the slow progression of kidney function which occurs, slow progression of the kidney failure which takes place in many of these patients once the creatinine has reached beyond a particular level. Once you correct anemia, there may be some improvement. But then it has not been conclusively proven that if you correct anemia, then definitely the kidney function will improve. Certainly, it is expected also, because once there is hypoxemia and there is other factors also which are associated with anemia, there may be worsening of the kidney function. But when you correct it, then there may be improvement. But then it has not been very conclusively proven, though there are 4 or 5 studies which have shown that there is improvement. But I think there is a need for more research work in this area.
Because that'll be very important and quite nicely summarized, because we certainly would want to know what really is the case, whether we are going to be able to slow down the rate of progression or not. And I think Dr. Rao also has asked a very pertinent question, and it's his observation that even with treatment, and Dr. Georgie Abraham, this is for you, sir. Even with treatment, hemoglobin levels can fluctuate significantly in CKD patients, and he wants to know how to manage such cases. I think what he's referring to is the concept of hemoglobin variability, Dr. Georgie, and how in your clinical practice you address the issue of hemoglobin variability, and how does it really come in the way of your management of these patients, Dr. Georgie, sir? The concept of hemoglobin variability, which Dr. Rao wants to know from us. Yeah. Dr. Georgie, sir? Maybe. Yeah. Can you unmute yourself, please, sir? You're on mute.
Hemoglobin variability.
Yeah.
I'm
Please.
on mute. Can you unmute me?
Yeah, it's fine now.
Can you hear?
Yes.
Yeah. So hemoglobin variability is one of the aspects of treatment of anemia with the earlier erythropoietin when they were short-acting. But this problem has become less seen when we had long-acting variants of erythropoietin when we started using it. So when you look at these patients, some people have gross variability of hemoglobin. It may be due to the iron deficiency, or it may be due to blood loss, or in some women who are menstruating during menstrual period, they may have menorrhagia. So hemoglobin variability is not a good aspect of our treatment of anemia and chronic kidney disease. How do we overcome this? And do you think that correcting the iron and correcting B12 and giving them enough folic acid and also correcting the inflammation by using whatever is available in our armamentarium, can we reduce the hemoglobin variability to a certain extent? Yes, because we know that the substrates are adequately replaced, but it may be related to either due to inflammation or intercurrent infections that the hemoglobin. We know that the patients, if they are admitted to ICU for some setbacks, the fall in the hemoglobin, and it may be related to nutritional aspect or it may be related to the inflammatory status. So hemoglobin variability is going to stay there unless we take care of this by looking at the substrates and also looking at inflammation and other things. But one of the things may be, when we start using HIF-PHI, it has definitely an anti-inflammatory effect, and it may be better tolerated in terms of as it is being given orally, tolerated, and may produce a better picture in terms of hemoglobin variability in patients with chronic kidney disease who are on dialysis and not on dialysis.
Well, thank you very
Hello.
much. That was
Hello.
very nice. Yeah, we can hear you.
Hello.
Please go ahead.
Hello,
Yes.
can you hear me?
Yeah, we can. Please
You
go ahead.
heard it?
Yeah,
Hello.
excellent.
Okay.
Yeah,
Yeah, that's what my take on this is.
yeah. Very nicely summed up.
Hello.
And I think you have told us very importantly that we have moved away from the older variety of short-acting erythropoietins, which we still are using. But then I think the world is moving more and more in favor of the long-acting erythropoiesis stimulating agents like darbepoetin or Mircera, the CERA, because we see less of hemoglobin variability there. But then I think we must be cognizant of the fact that there could be a lot of variation, diurnal variation. So it's very important as to what time of the day are you measuring, estimating the hemoglobin or measuring the hemoglobin, because it is going to have a reflection, because there is a very short therapeutic window of 10 to 11.5 grams. So we do not really want to exceed 12 grams, because we'll come back to that in a short while as to why. But then certainly what we have realized is that you should not be using very high doses of short-acting erythropoietin, something like 10,000 of erythropoietin units every 2 to 3 times in a week. That is going to be detrimental. This is what we have learned, that if you try to raise the hemoglobin against the erythropoietin resistance, you are going to have problems. And for those who have joined us today, just to give you a viewpoint, that if your patient is requiring more than 300 units per kilo body weight of erythropoietin when you had employed subcutaneous route on a weekly basis. So if you give an example, a 60 kilo weight person is given more than 18,000 units of erythropoietin on a weekly basis, you will call it as possible erythropoietin hyperresponsiveness. Dr. Georgie, can I request you to kindly mute yourself, because there was a bit of disturbance here. Then secondly, if you have used intravenous route, like so many times we do that in those patients who come to us for dialysis, if you have employed more than 450 units of intravenously given erythropoietin per kilo body weight on a weekly basis, you call it erythropoietin hyperresponsiveness. So my question to you, Avinash, is then how do you address erythropoietin hyperresponsiveness? What are the various causes? Do you believe it was probably because we didn't address the issue of iron in the best possible manner? Was that the reason? Dr. Georgie, one request one more time, sir. If you could kindly mute yourself for the timing, sir, please. Yeah. Avinash, can you unmute yourself and talk to us about the concept of erythropoietin hyperresponsiveness? How do you overcome it? The role of intravenous iron, because I had said a short while ago that so many times we find ourselves resorting to intravenous iron. So why so? And what do you have in mind when you are prescribing intravenous iron in these patients?
So we define hyperresponsiveness to ESA when we don't see a hemoglobin rise of more than 1 gram, even 4 to 8 weeks of
Where is
adequate ESA.
number two?
Dr. Georgie,
Oh, I have to
sir,
go.
maybe
Yes.
Dr. Georgie, can you mute yourself, sir, please?
I'm sitting in an airport. I have to board the flight now.
Oh my God!
They have
So
called me.
kindly, could you
So excuse
mute
me for
yourself?
this.
Yeah, please. It's okay. I mean, okay.
Okay.
Yes.
Okay. Thank you.
No. You're fine. We'll love to have you, but please mute yourself, please. Yeah. Okay. Avinash.
Yeah. So I think the question has two parts. One is where do we use IV iron, and the second part is about how to address ESA hyporesponsiveness, because they are two different. Or the ESA hyporesponsiveness has much more components than iron deficiency. So when we don't see a rise of hemoglobin of more than 1 gram after 4 to 8 weeks of ESA therapy, then we start labeling this person as a ESA hyporesponsiveness. And it can be really frustrating because the patient starts spending money on the erythropoietin, and then there is no change, or sometimes it even drops, and then we try to figure out what is really causing this lack of response. And we are assuming that the erythropoietin is of good quality. It has been stored well, and there has been no break in cold chain and all those things. I'm excluding from the discussion, and we'll come to the part where what else can cause this hyporesponsiveness. So we'll need to first of all rule out the obvious. Obviously, first we rule out that we have a sufficient iron stores, and if we have sufficient iron stores, that is the TSAT is more than 20%, we have a good ferritin level of maybe 200 to 300. Dr. Georgie highlighted the role of CRP, which will tell us if there is any excess inflammation or an infection, and it might provide a clue for us, especially if a patient has been on a temporary catheter or they're having a perm cath access. Both these could be sources of infection and chronic inflammation. There are a lot of patients are malnourished, and many of them reach dialysis in a very poor nutritional state. They have very low albumin, especially with the concept of no protein, or instead of low protein, they take a no protein diet. And it's very difficult to come back from that even after starting on dialysis. So addressing the nutrition becomes really important. Very high parathyroidism can be a cause for hyporesponsiveness. Poor RO plant maintenance and poor quality of water with endotoxins in it can also lead to this. If a patient is using ACE inhibitors, ARBs, RAS inhibition can also add to poor EPO response. So we need to rule out all these things step by step, because just increasing the ESAs is not going to overcome this problem. Instead, we'll also expose the patient to supra-physiological doses of ESA, which might lead to other complications of those, in addition to the cost which is added to it. So we would look at really normalizing the iron status first, and coming to part of the question which was put earlier, that where would be the role of IV iron over here. So this question actually comes particularly for non-dialysis patients, because for dialysis patients, IV becomes really the best way out, giving them during dialysis, reducing the pill burden. So predominantly we are discussing here probably CKD patients who are not yet on dialysis. So what the KDOGI guidelines said that if we should try oral iron first in non-dialysis patients, unless there are certain caveats to that. If their hemoglobin is below 10 and it is continuing to fall, they have documented iron deficiency where the TSAT is less than 20% and the ferritin also is low, less than 100. Also, if you're planning to use an ESA, we should make sure that we are giving them sufficient iron. And there is no point if we send someone to build a wall and there is no bricks to make it. So so when we are planning to start to use an ESA, we should make sure there is adequate iron, and especially if a patient has been on oral iron, we have not got an adequate response, I think IV iron comes into play. The reason there is hesitancy for IV iron, I think we all, and the patients don't like to be pricked. They don't want to get into the hospital. It needs certain infrastructure. And there was always safety concerns with the earlier iron preparations, I think, but now we are a little bit more comfortable giving IV iron with the newer preparations, where I think the anaphylaxis risks is extremely low, probably less than 0.1%, although no, not zero. Second worry was in earlier times when we had to give iron, we had to give multiple doses. And our CKD patients, we obviously like to preserve their IV lines when they reach to dialysis. But now with the newer preparations where we can give a bolus dose and do it within even a single injection or rarely a second injection, we can be a little comfortable giving IV iron, particularly in these situations. We do have other newer oral iron formulations which have come in and which don't use the conventional transport mechanisms. They bypass, so inflammatory influences are apparently less. But as of now, they still are expensive. And if we come to the collective cost, the added pill burden, we might actually land up paying more for those ions without still yet, I mean, I don't think we have that much evidence as how good they are in terms of improving hemoglobin versus conventional iron, and probably they're better tolerated. So we'll need to still, the jury is out on that. So I would come back to Dr. Kular with this.
Well, I think that's very nicely summed up, Vinash, and I think we can't go away from the fact that there's a definite role of intravenous iron therapy in our patients. It is easier for the patients who are on dialysis, but obviously it is a little more cumbersome to call the patients who are not on dialysis as yet to the hospital. But I think all that you need is maybe call them once in a month or once after 3 weeks, 2 or 3 times, and the iron stores are quite replete after that. So we did mention about the flip side of giving these patients a very high dose of erythropoietin, and we burnt our fingers. And that's when we realized that if you try to target anything more than 12 or definitely more than 13 grams, you are going to have a higher incidence of cardiovascular mortality, risk of strokes, the fistulae, AV fistula were getting clogged, and whole lot of vascular complications if you wanted to achieve those targets, especially if the patient was not really responding to the usual doses and you were making them receive very terribly high doses. So we heard a lot via the landmark hemoglobin trial, the CREATE, the COIR, the TREAT trial with various formulations, and one thing was in common: don't try to overdo things. So with that, Ritesh, my question to you is, have we become over defensive? Is it that anything more than 12 is a big no? We should never even attempt. It is like saying, oh, we were allowed only 60 km/h of speed on the highway or not, or in the usual. The moment it is 62 kilometer, I mean, as if you get your heart sinks and say, oh, I need to go back to 50. So is that kind of situation, or is it something more to where these patients could have a problem? Ritesh.
Yeah. So basically, so you've already told that in the 3 trials, whenever we went up above 11.5, there was increased risk of cardiac events, and there was increased risk of stroke also. So the problem is that whenever we are going higher, it could be, earlier it was thought that it could be because of a rheological effect. But later on, it was understood that because we are using the supraphysiological dose of erythropoietin to address the hyporesponsiveness in these patients, because many of these patients were receiving very high dose of erythropoietin, and that was the factor which was causing increased incidence of cardiac events. It has been seen in few studies also, in the cardiac studies also, that like the red HF, that whenever the hemoglobin was increased, there was no improvement in the mortality or the cardiovascular events. So whenever we are going above the target which we are achieving at present, there was no added benefit of decreasing the cardiovascular events or mortality. And in the initial studies, whenever we are going above 10, that is the time what we are seeing is that the LVH, the left ventricular hypertrophy, is coming down and the cardiac dysfunction is improving. That was the time. Till above till 11 we could see those things. So when we start going above 11.5, the added benefits were not seen, and I think that is why we have become more cautious and not going above that, sir.
Well, thank you very much. There's a sudden bombardment of questions, and I think very interesting ones. I think this discussion could go on for another couple of hours, the kind of questions we have. And I think this one is very, very important. This one is for you, Dr. Georgie. Dr. Georgie is here, I believe, or did he have to leave? He was at the airport. And if he's not there, I may request Dr. Kalra to take it up. Dr. Surinder Gupta from Ludhiana wanted to know the role of family physician in management of anemia and CKD patients. How can they help in its prevention? Because you see, as I said earlier, that it is humanly impossible for a handful of nephrologists to be comfortably manage the huge burden of CKD in our country. So it has to be at the hands of the primary physicians, the people who first are in contact with these patients. So when should a general physician refer CKD patients with anemia to a nephrologist, and how long do you think they are good enough to manage these patients? I would have loved Dr. Georgie Abraham's comments here, but then in his absence, maybe Dr. Kalra, you could take this up.
You want me to say?
Yes, please. In fact, I don't find Dr. Georgie. I think he was at the airport. He must have left. Yeah.
Uh, Although, I mean, right in the beginning, you mentioned that since the nephrologist population is really not so much despite such an increase over the last few years, but the burden of disease of anemia affecting the chronic kidney disease patient is so much that nephrologists just cannot treat these. So therefore, general physicians have to come forward. But if we look at our prescriptions which come to us with referral from the general physicians, hardly we find not really more than 2-3% patients have been put on erythropoietin, or IV iron is still much lesser. Most of them are still on oral drugs. So therefore, there is a great need for orientation and, of course, a continuous learning for all of us along with general physicians that when to treat these patients. Of course, the general physicians should take initiative, monitor the iron parameters as we have already elucidated in these patients of chronic kidney disease, even in the early stages, frequently at the frequencies that we mentioned earlier, particularly in CKD5 every 3 months. And they should be given intravenous iron. And now with the current availability of FCM and also ferric isomaltoside. I mean, it's not really so much risky to give this intravenous iron preparation in these cases. And erythropoietin should be given even at the level of general physicians. And as far as choosing between erythropoietin and the oral drugs are concerned, because sometimes they hesitate in giving subcutaneous, it is proven beyond doubt that erythropoietin should be the first line of treatment, not the oral desidustat. Although, I mean, it's a relatively recent entrant into the field of, erythropoiesis stimulating agents. But then, certainly, we need some more experience with this, some more trials before we really recommend it as the first line. So, first line treatment has to be this. But certainly, if a physician has already seen that all the treatable, correctable causes have been taken care of, still the patient is not responding, and of course, if a patient is overtly uremic and requires dialysis, without subjecting the patient to regular dialysis, we can't expect a dramatic improvement in these cases. So therefore, but in the pre-dialysis stages, if the patient is still not improving, then we need to do certain other investigation in the form of extended panel of investigations to rule out underlying parathyroid problem, thyroid problem, occult blood loss, or other things. And if we still are not able to do that, then we should refer the patient to nephrologist so that they can further investigate these patients and treat these cases. But first line physicians must take initiative to treat these cases.
Very, very important. I think otherwise there is no point having all those weapons in our armamentarium if there are not enough people to wisely use them for the effective management. So I think we're running short of time. A quick rapid buzzer, and I think I'll take up a few questions, which very interesting ones, which have been posted in the group. And Dr. Kaur wanted to know any comments on pure red cell aplasia and CKD. Well, that is something which we were seeing a lot with the original innovator brand Eprex, because that was with the rubber clock, especially which was associated with PRCA, and they formed anti-erythropoietin antibodies subsequently with the use of intravenous and the better subsequent population formulations in even their own improvement on their product. We are not seeing it, thankfully, very, very often. Dr. Mohit Gupta wants to know if patient who has allergic reaction to even ferric carboxymaltose, what to do? Should we shift on to an alternative or don't give IV iron? I think, correct me if I'm wrong, Puneet, I think maybe we can use an alternative IV cautiously, because it may happen with one, not necessarily with the other. But then one thing which you must remember with ferric carboxymaltose is also the effect on phosphorus, which can at times go down, which is actually something which we desire in our patients of CKD, but then for normal population, it may be detrimental. Dr. Gupta wants to know that the ferritin levels at times are very, very high, something like 1500 to 2000, what to do? And I think to address that issue is to understand the concept of hepcidin. And with that in mind, we are having very promising drugs called HIF-PHIs, which we had talked about earlier. Very important concept, because please, just to make a simplistic approach to this newer concept, there is HIF alpha and there is HIF beta, which need to come together to start making erythropoietin. So what happens in normal hypoxic, normoxic conditions is there is something called PHD, pyrrolyl hydroxylase domain, which does not allow the two to join. It degrades HIF alpha via the von Hippel-Lindau pathway. And if we take out PHD, this happens typically when we go up in the mountains. At the high altitudes, the pyrrolyl hydroxylase domain gets inhibited. So people came out with a novel idea of making drugs called HIF-PHIs, which inhibit PHD. Now the pyrrolyl hydroxylase domain is not there. So there is nothing to not to allow HIF alpha and HIF beta to dimerize. They come together and a chain of events starts when they get translocated into the nucleus of the cell and a whole lot of genes. But the worrying thing here was it is not the erythropoiesis gene which they address. They could actually be stimulating many oncogenic genes as well. There could be increase in the retinopathies, in the increase in the peripheral vascular disease, cardiovascular disease, whole lot of things. That is why Dr. Georgie Abraham said that the US FDA is not so much gaga about the role played by HIF-PHIs. They need more thing. But an Indian company has come out with a very effective drug, and we need to know more about these. If no significant malignancies happen over the coming few years, we can repose our faith more and more in these drugs, because they are big. They are oral drugs. They take care of hepcidin also. They help in the iron assimilation, and it's a more physiological way of addressing erythropoiesis in these patients. But then, yes, we need to have more. And we are told that almost close to 2,000 people have logged in today as well. Dr. Puneet, would you want to take it up? Dr. Bhatt wants to know the role of vitamin B and folic acid in anemia of CKD. A quick, short one for that. Yeah.
As compared to iron deficiency, the chances are less, but still it is there. Sometimes when the erythropoiesis is fast, so iron get consumed, and simultaneously with the rapid increase in hemoglobin, the B12 and folic get depleted. So
Right.
if there is a hyper responsiveness to ESAs, iron, then you need to check this also.
Dr. Subha wants to know whether, since ACE inhibitors, as was alluded to by Dr. Kalra, that they can inhibit the synthesis of EPO. So, should we really use them because they are renoprotective? I think the answer is very clear. We should not come in the way of optimal use of ACE inhibitors. If anemia comes in the way, we have effective tools to manage anemia as well. But certainly, ACE ARBs have a very big role to play in the management of chronic kidney disease, apart from so many other conditions. Dr. Hadia wants to know the role played by SGLT2 inhibitors because they also work similarly and they help in management of anemia. Well, whole lot of questions. There are at least 20 more in the chat box, but I think there's paucity of time. Ritesh, any last minute? And I think I'll be feeling in my duty to acknowledge the hard work of Dr. Kulwant, my dear colleague here at Department of Nephrology, Max Saket, who has been working very tirelessly to behind the scenes effectively control the flow of events.
Thank you,
And
sir.
thank you very much, Kulwant, for all your help, all these sessions. Well, if Ritesh, any last minute comment on what we may have inadvertently missed out on? I'm sure there are a lot of aspects which we have not been able to touch today because of paucity of time, but it was just an overview because this is such
Yes,
an important topic for the management. Yeah,
So
Dr.
I
Dinesh,
think
one small point I want to mention.
please, please.
Actually, during all this discussion, we haven't really talked much about the role of protein intake. We know that hemoglobin is composed of heme and globin components. And for heme, we need to give iron because protoporphyrins are there. We need to give B12, folate, and all those things. But as far as coming to protein is concerned, many of our patients are not really taking adequate amount of protein, even though they may be on hemodialysis. So we need to emphasize it again and again. We keep on giving them coenzyme Q and also even carnitine, but then all these things are there if we give them good quality proteins. So without protein, the globin will not get synthesized and hemoglobin will not be formed. So therefore, this needs to be emphasized again and again.
Absolutely, point well taken, sir, and especially to the vast Indian vegetarian population. Since we learned in the beginning that we need to restrict the protein intake, we had been doing it very, very wrongly. And even to those who were not having adequate intake of protein, we were telling them not to further reduce their protein intake. That was actually a sin which we have been committing, but probably, hopefully, not in the future because we've learned in a much better fashion as to what we need to do as far as the protein intake of these patients is concerned. Ritesh, you have the last word today, and before
uh,
I hand it over to Mithilesh. Yeah.
yeah. So basically, the role of SGLT2 inhibitors in increasing hemoglobin, that could be a good agent which can be used after iron therapy in patients with heart failure and chronic kidney disease, and that we should be using, and we should emphasize on that also.
Thank you. Over to you, Dr. Mithilesh. This discussion could go on and on. Such an important topic. Yeah.
Yeah, thank you very much, sir, for providing a valuable insight on the anemia management at CKD. We learned so many aspects from the pathophysiology to diagnosis and management, role of hepcidin, the how we can use the various parameter in the diagnosis, especially the ferritin and T-set, how they are useful in the diagnosis aspect. Reticulocytes can also be one of the important aspect in the diagnosis of anemia in CKD. Beyond that, we also learn about the various medication, how they are useful, and what are the limitations with their use in the treatment of anemia. So, special note of thanks to our speaker, Dr. Puneet Arora, for delivering this insightful talk on the anemia management in CKD. I would also like to sincerely thank our esteemed panel member, Dr. Abraham, Dr. Rajesh, Dr. Ritesh, Dr. Avinas, and Dr. Kalra for their thoughtful contribution and providing real-world clinical perspective during the engaging panel discussion. As always, we extend our heartfelt gratitude to our esteemed course director, Dr. Dinesh Kullar sir, for his visionary leadership and for shaping this Nephro Live into an academic platform of profound value. Thank you to our audience as well as for their active participation and enthusiasm. Their participation make us more motivated and doing more such episodes in future as well. So we look forward to welcoming you to our next episode with another important topic. Till then, good night and take care.
Thank you very much, everyone. Thank you,
Thank you,
all
sir. Thank you so much. Thank you,
the
sir.
speaker
Thank you.
and the
Thank you, sir.
panelists. Thank you for a wonderful job.
Thank you
I
very much.
thoroughly enjoyed learning a lot from you. Thank you so much.
Thank you, sir. Thank you.
Thank
Thanks for your time,
Thank
sir.
you very
And
much,
the
Dr.
final,
Puneet.
sir, the final count is 197.